is membrane surgery with cutter. So what we're doing here is a 25 gauge vitrectomy with vitreous hemorrhage and a TRD. So you can see the surgery. So we're pretty much able to peel, segment, as well as delaminate. I'll show you the same parts in the interest of time. I'll just show you the parts of the same surgery in subsequent slides. So membrane surgery, the question she'll answer is which case do we select to do only with the cutter? But of course we should be ready with all the instruments, but we can mentally plan which are the cases which we can do only with the cutter. How and what are the gauges? So which case? So in my opinion, these are the cases. A little vascular prolapse with or without anti-VEGF. If it has become fibrous prolapse, then it becomes a little bit difficult to peel the whole thing just with the cutter itself. So it should be a little fresher PDR where it is just about becoming fibrous or it is still vascular. We have given an anti-VEGF and it's become a little fibrous. So those are the ones which are easy to peel off because the vascular nails anchoring the fibrous tissue to the underlying retina are not strong enough and they can be peeled off easily. And as I mentioned, a new TRD. So it's usually not for predominantly fibrous prolapse or ischemic thin atrophic retina where there is an increased propensity to cause breaks. In those situations, it's better to use the scissors. How? Segmentation. So you can lift up a little bit, and if once we are sure that there is a gap between the fibrous tissue and the retina, we can go and cut it and segment it. So delamination. So this is the keep the cutter on the surface of the fibrous tissue, allow it to peel inside, and once it is done and segmented, then we can go ahead and delaminate it as well. So you allow it to peel, you roll the fibrous tissue into the port of the cutter. And the most important, the second membrane. So this is the visible fibrous tissue, and you see this is the invisible fibrous tissue, not here. So this is the invisible fibrous tissue. And once the second membrane is peeled, then the whole fibrous tissue comes inside. So the problem is in the second membrane, the anterior vitreoskitic membrane. If that is not identified, then it's very, very difficult to do this surgery just with the cutter itself. So the anterior second membrane, once it is identified and once we peel it, then we're in the correct plane. As you can see, it bleeds lesser, the chance of breaks is also much, much lesser. So another patient, one of my colleagues is operating, so he's struggling with the combined retinal detachment and thick fibrous tissue. Going on peeling, and then so the problem in this situation, when we have a combined retinal detachment and the thickly identified fibrous tissue is that it can become bullous. And if you have not removed most of the vitreous and it becomes bullous, it becomes extremely difficult. And the chance of iatrogenic breaks is quite high. So in these are the situations, better to shift to bimanual surgery much, much earlier. So the questions which we'll be answering in the next few slides are location of the chandelier and getting the best of the chandelier and crucial steps where chandelier plays a role. So Dr. Puneet has mentioned some of them. Single probe, best is to put it opposite the side of maximum dissection so that the area of maximum dissection is illuminated very well. And double probe, it can be put in two different quadrants away from the aqueous scleroderm as you can see out here. And some of the techniques is we can manipulate the chandelier as like a light pipe itself by holding it. So bimanual surgery, but one hand is holding the chandelier. Other one is the angle of the fiber. So lift it up, it goes more posterior. So a little bit posterior, 90 degrees posterior pole is illuminated. Pull it out, then it kind of bends. It bends in the opposite direction, you can do that. So you can do these manipulations to illuminate the chandelier better. There's one surgery where we can use the single chandelier which I'm using, a 23 gauge surgery. So as you can see, there is a large dark area here. So this can be covered if you were to use a double chandelier or by asking the assistant to tilt the probe a little bit outside. And this you can see this is an extremely like an end stage case with a total retinal detachment, extensive subretinal exudates, combined RD and a thick fibrous tissue. And these are the situations where bimanually we hold and cut. And contrast to what we think, the the scissors hand could be the non-dominant hand. It's much easier to cut, and the dominant can hold the forceps and peel it. So that's the last part. PVD induction and proliferative diabetic retinopathy. The tips. The PVD induction is not like any other retinal detachment. So this is the technique which I follow. You can see this is a patient with the proliferative diabetic retinopathy and posterior hyaloid which is attached here. You can see that's the NVD. So lift up the posterior hyaloid a little bit, trim it. And so that's the thickened posterior hyaloid, incise it, lift it up. So the basic aim is not to peel off wherever it's attached. We cut around the vascular nails. So this is the VMT. So as you can see, we go around it, and the tangential traction decreases the risk of a break formation. So tangentially, if you peel it directly straight ahead, then there's a risk of a break formation. And wherever you see these vascular nails, we go around it, lift the vitreous a little bit, cut it, lift the vitreous a little bit, circumcise it. That way, the risk of creating a break is much, much lesser. And once it is completely free, then we can delaminate it with the cutter itself. This way, the risk of creating a retinal break and increased risk of bleeding is also much, much, much lesser. So we do this for each of these proliferations. And as you can see in this patient, the more fundus details we are able to see, more difficult is the diabetic surgery because the PVD is not there. So that's pretty much the diabetic vitrectomy part which I want to cover.
Thank you, Mahesh.